film you are about to witness is presented to you frankly and completely. It is the story of the problem of venereal diseases in the military service from a medical standpoint. Lights out.
As an officer of the Army Medical Corps, I wish to bring your attention to an important risk, that of venereal diseases acquired during the sexual act. This is the specific germ of syphilis. These germs, if allowed to enter the body, either through the skin or through mucus-lined openings, may destroy your life. Let me emphasize, it is extremely important that you do not...
50 years ago, syphilis was the scourge of society. This once debilitating and sometimes fatal sexually transmitted disease occupied a major place in the study of medicine, and prevention campaigns like this one were commonplace back in the 1940s. Today, AIDS has become the new public health menace threatening the world. Thousands of scientists, along with AIDS activists, gather every year at large conferences like this one. But there are some people here who aren't so sure we're really seeing a truly new disease. John Scythes can't believe syphilis has just disappeared.
It's conspicuously absent in all HIV disease when it's later stage. It's a 100% correlation. No AIDS patient ever dies of syphilis, and that's impossible, because we know we only treat half the syphilis in any sexually active population. There's dozens of references to that. The British shook their fingers at the Americans in the 70s. I have the references. Look out, you're not picking up the syphilis in your homosexual populations. Warnings, you're only getting a third of it, you're only getting a half of it, and along comes HIV disease and the syphilis disappears. I can't accept that.
Hello, I'm Coleman Jones. In the last program in this series, we looked at one of the most highly associated risks for becoming HIV positive and developing AIDS. That is, a history of sexually transmitted diseases, STDs. Several studies have shown that the rate of disease progression among people with HIV is correlated with a history of STDs, and other studies show that a prior bout of syphilis in particular is an even greater risk factor for becoming HIV positive than high-risk activities. Although the early stages of syphilis respond very well to penicillin, the disease can often be missed or mistaken for other conditions. It can then lie dormant in the body for many years, after which it becomes increasingly difficult to treat. Besides the outward symptoms involving destruction of tissue, syphilis can also have pronounced effects on the immune system. And there was quite a debate back in the 1940s and 50s over whether syphilis only kills people through the direct effects of tissue destruction, or whether it could also render people more susceptible to other life-threatening infections and cancers. Although the concept of immune suppression wasn't particularly well understood back then, there seemed to be a lot of it going on, based on what we know today. The syphilis and dermatology texts from that period contain references to deaths from all the same viral, bacterial, and fungal infections that kill AIDS patients today. One of the few people who's made a detailed investigation of these early cases is Michigan State University professor Robert Scott Root-Bernstein.
AIDS is not new. I seem to be one of only 2 or 3 people who bothered to take the time to go back in the medical literature to actually see whether there are cases that meet the current definitions of AIDS. And using the CDC's own definitions, you can go back to the very beginnings of almost every single opportunistic disease which we use to define AIDS and find cases that match that definition.
These include everything from disseminated cytomegalovirus, herpes zoster, tuberculosis spreading outside the lungs onto the skin, and the tumor-like growth called Kaposi sarcoma, which not only affected older men, but could also strike young people, often proving fatal.
There are literally hundreds, and I believe probably thousands of such cases which I've been able to document in the literature, indicating that AIDS is not new. We simply didn't have a category for describing these patients, nor did we realize that somebody who had cytomegalovirus had anything in common with somebody who had Kaposi's. So we did put them together until about 1980.
Even more AIDS-like cases have been uncovered by Toronto researcher John Scythes.
AIDS is relatively new in America and shockingly and horrifyingly new to the homosexual community, but AIDS is not new.
Another reason that I think AIDS appears to be new is that the risk factors associated with it have grown tremendously just in the last 2 or 3 decades. Again, the evidence is sitting in the medical literature and has been ignored. If we go back and we look at gay life, for example, we find in the Kinsey Report in 1948 that the average gay man had a sexual encounter perhaps once every couple of months or perhaps once a year. That changed dramatically. When we look at AIDS patients, the average AIDS patient will have had several hundred or even several thousand partners in a matter of a few years. So we have a change in gay life. Now, one would expect that if this change in gay life actually caused medical problems or was associated with them, we'd find that in the medical literature, and in fact we do. We find increases in sexually transmitted disease defined in the literature almost totally with gay men, such as gonorrhea, syphilis, increasing 300 to 400% between 1960 and 1980.
Syphilis became a homosexual disease. The epidemiology is compelling. It became, statistically, if you look at the American and British records, it migrated from 5% in homosexuals in the 50s to 67% in homosexuals by the late 70s. That's remarkable. Yet the amount of syphilis in the two countries went up and down, sort of as one might expect, but the disease migrated to the most incestuous community, which was a relatively small number of men who were having an awful lot of intimate contact relative to a larger segment of society.
Bob Lederer hosts a radio program on AIDS treatments and works with ACT UP in New York.
In the gay male community of the U.S. in the 1970s, because of gay liberation, because of the freedom for us to express ourselves sexually for many of us, what it meant was the ability to have repeated sexual encounters with large numbers of men. Not for all of us. I'm not saying that that happened in all cases, but for a large subset of our population. And the result, one result of that, and this is not casting a moral judgment on it, because I think the gay liberation movement has been a wonderful advance for all of us, but an objective fact is that sexually transmitted diseases exploded in the gay male population in the 1970s in this country.
One of the reasons for this explosion was because the usual ways of controlling sexually transmitted diseases, such as contact tracing, effectively broke down because of the anonymous nature of most of the sexual activity. This British 1975 text quoted a leading STD expert who proposed back in 1964 that syphilis could be eradicated from the USA by 1972 if 30% of newly infected persons were treated before the disease was transmitted. He did, however, note that this would not be possible unless the family physician cooperated with the control program and reported the cases as they were diagnosed. As can be seen from the statistics, the control program failed. Private physicians treated 82.8% of all cases of primary and secondary syphilis in the USA, yet only 12% of the cases of infectious syphilis were reported to the government authorities to allow control procedures. Joan McKenna, who's been studying the relationship between syphilis and AIDS since the early 1980s, points out this effectively allowed syphilis to run wild.
Middle class and upper class people who were exposed to syphilis, often the physician never tested because he wanted to save his client the embarrassment of a public health survey, public health contact tracing, and would just say, here, take these pills and go home and send your little friends into me, and I'll treat them too. Let's just take care of this ourselves.
As a result, in the 1974 edition of Harrison's Principles of Internal Medicine, syphilis authority King K. Holmes wrote, "Private physicians who treat most cases of early syphilis report only 12 to 19% of such cases. Inadequate tracing of sexual contacts of unreported cases is the major factor responsible for the resurgence of syphilis in this country." But as Joan McKenna points out, this wasn't the only reason syphilis was getting out of hand.
We also found that there was a phenomenal amount of prescribed drug use. And the prescribed drug use included what we would consider abusive behavior, abuse in the prescription drugs. This included the use of tetracycline for up to 18 years for the possibility of a pimple. It included erythromycin being given as a before and after pill for going to the bathhouses.
Many well-meaning gay doctors or straight doctors that were sympathetic would actually give prophylactic antibiotics, would say, well, we know you're going out to the bars and the baths tonight or this weekend or whenever, and we know that you're probably going to pick up something. So why don't you just take some of this tetracycline as a preventive?
And they did not understand that if you have an altered chemistry and the level of the antibiotic is not sufficient to kill the microbe, what it creates is an environment in which the host response changes and the microbe changes.
Just because a drug that can temporarily cause a cessation of symptoms of this disease and you can go back to living your life doesn't mean that everything's fine and there's no lasting effects of having the disease or taking the medicine.
At the 1992 AIDS conference in Amsterdam, I discussed this problem with Dr. Edward Hook. He's a leading American syphilis authority, formerly chief of infectious diseases at Johns Hopkins Hospital in Baltimore, and now with the University of Alabama.
Today, we live in an antibiotic-laden society in which people take antibiotics for any variety of different things with remarkable regularity. And many of those antibiotics have some effect against Treponema pallidum, so that we're in a situation in which it's likely that many people have been partially treated, and the question then becomes, is that partial treatment going to reduce the manifestations of classical and typical syphilis? I think it's likely that that's the case. In a recent study that we performed at Johns Hopkins Hospital, and this was not necessarily in HIV-infected patients, but just in patients admitted to their hospital, we could find that 12% of patients admitted to the medical service of that hospital had serologic evidence of syphilis. They had no evidence of active disease, but they did have serologic evidence of infection. And about half of those people had no history or knowledge of having had syphilis.
This May 1970 report in the journal California Medicine stated that far from eradicating syphilis, these antibiotics are driving the disease underground and increasing the difficulty of detection. Although the incidence of disease has more than tripled since 1955, the chancre and secondary rash no longer are commonly seen. Undoubtedly, some of these lesions are being suppressed and the disease masked by the indiscriminate use of antibiotics. They added, the ominous prospect of a widespread resurgence of the disease in its tertiary forms looms ahead. In this 1986 text, syphilis experts Conrad and Victoria Vischer, quoting the U.S. Centers for Disease Control, estimated that a reservoir of 325,000 untreated cases existed in the U.S. Other authorities agree the number is closer to 500,000.
There are a large reservoir of individuals who have probably had syphilis in the past and are untreated or do not know that they've received therapy, which may or may not be effective for syphilis. The question that, of course, comes up then is, in those individuals, what is their risk for then going on and developing catastrophic consequences of their infection? And that's simply unknown.
In the absence of typical symptoms, diagnosing syphilis depends on serology, in other words, blood tests. But the reliability of these tests, especially in people with HIV antibody, is coming under increasing scrutiny in light of various anomalies uncovered by Joan McKenna and doctors here in Toronto. It's important to note that the blood tests for syphilis don't detect the actual organism, Treponema pallidum itself, but instead measure one part of the body's immune response against a syphilis infection, in the form of antibodies. These tests come in two basic types. The first, known as the VDRL or RPR, is a non-specific test, meaning that it can be positive in other conditions as well. The VDRL looks for a fourfold rise in the amount of a particular set of antibodies directed against the body's own connective tissue, cardiolipin. Why this anti-cardiolipin antibody is produced and its role in the protection against the disease is simply unknown. But it became the first to be associated with syphilis and used to be called reagin or reagent.
Now, a reagent test measures whether or not there's a general inflammatory response happening in your body that has certain characteristics that could be syphilitic. If you have a reactive reagent test, then they will call you back in, take more blood, and do a confirmatory test. The confirmatory test will be a test for specifically for treponemal antibodies. These are the antibodies formed by T. pallidum, which is Treponema pallidum, which is considered the microorganism for syphilis. If one of those tests turn reactive, it is then considered a conclusive diagnosis that you have syphilis, that you have an active case of syphilis, and then you'll be treated.
The question I have is that the serology of syphilis does not adequately indicate when a patient is reinfected. That's a major problem. The VDRL fourfold rise is an assumption which occurs in immunologically intact people that were treated early. In other words, you have to be treated very early in syphilis for the screen test to work again. If you get treated as a seropositive, reagin-positive secondary syphilitic 6 months into the disease, you will not make those symptoms again. That is, a chancre or a rash. Very rarely. So therefore, how do you get diagnosed when you get another infection?
I'm Dr. Richard Freilich. I'm the clinical associate here at the immunology clinic at the Toronto Hospital, Toronto Western Division. Quite interestingly, when we looked at the VDRL or screening test findings for syphilis, we did not find any reactive test results. And it makes you wonder, is in fact the VDRL sensitive in this high-risk population to be able to detect if there is, say, something like neurosyphilis becoming evident. And there's certainly some reason to think that the VDRL may not be sufficiently sensitive in this high-risk population.
And as Joan McKenna found out, the tests looking for specific antibodies against syphilis may not be all that reliable either.
What we do, usually when you're a healthy person and you have syphilis and you're treated for syphilis, you have what's called a serum scar. It means you have antibodies, treponemal antibodies, that would show up on the FTA or the MHATP tests. Usually, unless the person was very young when they had the syphilis and it got treated, or you're dying and your whole system is going wild, you show treponemal antibody for the rest of your life, pretty much. What we found when we did check the individuals who were in our program who had a history of syphilis is that over 50%, 70% in one series that we did, 53 to 54% in two more series that we did, had lost their treponemal antibodies. They were now non-reactive. And that meant we were technically blind to detect syphilis in these individuals.
Starting back in the late 1980s, doctors at the Toronto Western Clinic have been looking into this problem.
Our particular interest in this area of syphilis and HIV comes out of earlier research which Dr. Douglas McFadden, who is the founder of the Immunology Clinic, had undertaken 3 or 4 years ago that had, for one thing, identified that this existed, that there were individuals with HIV who had, in fact, a latent form of syphilis infection. And this more recent study was to review and update those earlier findings and look more specifically at the level of immune problems or the immune suppression that a given patient might have, and try to correlate those clinical and laboratory findings with the evidence of latent syphilis infection.
The study found that of the 54 patients with treponemal antibody, 11 or 20% had no history of ever being treated for syphilis. Another 6 with a past history had lost their treponemal antibodies. Freilich and his colleagues decided to compare their immune status with those who still showed this marker.
Among the group of patients who had lost their treponemal antibody and were showing negative on that test, they in fact had more severe immune suppression. On average, their CD4 count was in fact 78, whereas if we look at the individuals, all the individuals who had positive tests, positive treponemal test results, their average CD4 count was 272. Now, admittedly, there was a wide range among that larger group, but it's significant that we were finding that the loss of treponemal antibody was correlated with more advanced immune suppression. And certainly having that type of chronic latent syphilitic infection could contribute to immune damage.
This apparent loss of treponemal antibody, which effectively obscures a past syphilis infection, seems to occur independently of other antibody responses. This poster, presented by the Ontario Ministry of Health's Chief Serologist, Dr. Bob Notenboom, at the Amsterdam AIDS Conference, said, having confirmed the decrease in treponemal antibodies in persons with HIV, we have shown that this phenomenon does not affect antibodies of a different specificity. The evidence strongly suggests that the loss of treponemal antibody is selective. Joan McKenna found out that giving antibiotics to a group of 10 men who'd lost their treponemal antibodies had an intriguing effect on their blood profile.
We found, looking at following these patients over a year's time, that within the first 10 months, 7 out of 10 of these men went reactive on their serology.
We have seen situations where patients have lost their treponemal antibody and then where they've in fact been treated for a late latent syphilis, that in fact there has been a return of that treponemal antibody.
How would you explain that?
If we don't look at this more closely, then we won't find out what it means. But we're very suspicious looking at the HIV question. Syphilis is much older, very capable of being latent, and very capable of being low grade in people who aren't healthy. So it won't show its normal cards, like a reactive screen test, so it won't get treated.
We found that there were individuals with untreated syphilis where that was only detected on the treponemal test. It was not detected on the VDRL test. Overall, we did not have any reactive VDRL tests, and yet the VDRL it's the classic test that's been used to screen populations, to try to determine if a person does or doesn't have some type of syphilitic infection. And here in our population, it was non-reactive across the board.
In other words, the patient does not make reagin or anticardiolipin antibodies, so that the doctor diligently and faithfully throughout the 70s screened at his STD clinic his patients, and he missed the syphilis.
I think our study demonstrates that there is some weakness to the current tests. I think on the positive side, the very fact that we look at treponemal antibodies routinely is at least helping us to detect what was previously undetected in terms of latent syphilis. But I still have to consider that the VDRL was not sensitive to, did not appear to be sensitive to indicate that there was any evidence of reactivation, and I think we have to be looking at newer types of blood tests for syphilis.
It's far from over and far from simple. It's not. It is an extremely we have used very crude butcher knife tests to deal with a very complicated immune response.
So that area of research has almost been totally ignored, especially since the advent of penicillin 40 years ago. So what we're left with is a technology of test kits for syphilis that is 40 years behind the times. You know, whereas HIV antibody test kits are state-of-the-art, high-tech biotechnology, genetic engineering, and not surprisingly, high-profit areas.
We've had to rely on measurement of treponemal antibody, but I mean, there's some indication that it's not the best measure. I mean, it's where we realize that this is syphilis is an infection that relies on cell-mediated immunity to be able to combat and control it. And here we are measuring, in fact, specific antibodies which are not directly related to the cell-mediated immune response.
I think when the question of syphilis testing is addressed in the manner that it should be, and real money is put into developing a more sophisticated test, that we will begin to uncover a mountain of undiagnosed syphilis cases, and perhaps then more light will be shed on the AIDS and syphilis connection.
To be able to address some of the diagnostic dilemmas that occur with syphilis and HIV, we need to be able to look at, in fact, measuring the extent of cell-mediated immunity directed against the syphilis, and being able to understand how T cells, T lymphocytes are responding to the detected form of syphilis infection in a given patient.
And it very well may be that an effective cell-mediated immune response is necessary for antibiotics like penicillin to work. This was tried by a New York doctor, Stephen Kayatsa, but it didn't seem to help the handful of patients in Toronto who convinced their doctors to treat them this way.
For instance, when Steve Kayatsa came here, a number of patients elected to take penicillin therapy, and their doctors kindly obliged them. It precipitated terrible reactions, massive sciatica pains in the leg nerves, terrible fevers, often a week or two after the administration of the first injection of 2.4 MIU-IM, that's the regular benzathine penicillin. In hospital, courses have caused treponemal antibody titers to jump around, especially to become reactive again in a couple of patients. So have people been cooperative? You betcha they have. In other words, what else can you do? If the treatment is dangerous to the patient and makes him less well, even if it's intriguing serologically and symptomatically, you certainly don't suggest it as mass therapy.
Stephen Kayatsa treated people in his office with benzathine penicillin. He then gave them doxycycline for some extended period of time. There was improvement. Definitely there was improvement, because there is at least some antibiotic being available to the system, and there's a diminishment of the antigenic load because of that. But it's not curative. And there's some who believe penicillin has never cured syphilis. Part of what we have to do is we have to look at penicillin again. We have to look at what we're doing in terms of treatment therapies.
Penicillin has no effect on latent syphilis to speak of, by definition. The bugs are not dividing, penicillin cannot hurt them. Beta-lactam drugs affect only organisms that actively are proliferating. But don't tell me that the giving of antibiotics causes nothing to happen in HIV-positive patients with CDC3 and 4 AIDS. CDC4 AIDS, it causes terrible reaction. And there's no sign that it's the mast cells going crazy. They don't get redness at the site of injection. They don't have anaphylactic shock. It's not that. It's a reaction to the effects of the drug trying to deal with latent treponemal infection and failing because the bugs are not dividing.
If penicillin was the only answer, all right, we would all be in trouble. But there are a lot of instances now where we're finding that people are able, through natural medicine, through ozone therapy, through other forms of antibiotics, other forms of herbs and drugs, that are able to make a change in what is happening with the treponemes. All of it needs to be evaluated.
For the time being, doctors at the HIV clinic at Toronto Western are doing what they can by offering a standard course of antibiotics to patients they suspect may have untreated syphilis.
But we don't have an actual blood test measurement to say that, well, the test has gone from this result to that result, and so therefore we've done a good thing.
Another possibility is a technique called selective immunogenesis. That is, using specific proteins of Treponema pallidum that might boost the cellular immune response. It's not clear, however, which proteins to use out of T. pallidum's complex genetic structure.
Remember I said T. pallidum is a big enough bug to code for between 450 and 500 proteins, not like little HIV with this GP and that core protein, right? That's a tiny bug. T. pallidum is a battleship. So if it gets loose in you and you're not well, and it doesn't divide, remember, if it doesn't divide, we have no treatment. So if T. pallidum is residing in immunologically privileged sites, it will poison you to death, by definition, by my literature, which is extensive, 3 feet spine out. Since AIDS requires an infectious and persistent pathogen, in my opinion, this is where I disagree with Joe Sonnabend. I agree with everything else he has to say. But I think AIDS requires a persistent and unrelenting immunogenic stimulus, because too many of our friends have taken excellent care of themselves for several years once they discovered they were HIV positive, and this was to no avail. And you would think that if it was multifactorial, and most of the factors are things which are associated with disease process outside the age risk group, that is, other people get hepatitis, other people have cytomegalo infection, other people have EBV, other people have positive herpes serology, other people get herpes zoster, but they don't get sick and die. You have to take all of this and say, well, yes, this total thing is dangerous, this total amount of immune load is dangerous, but there's still, I think that's where the antibodies to HIV were, in the mid-'80s, extremely compelling evidence that there was a persistent pathogen and that it could have been of viral origin. And that's why I can see why the establishment has clung so tightly onto HIV. I think if they understood T. pallidum infection a little bit better, they'd realize that it can reside in hosts, penicillin notwithstanding, and that if you're not well and you are reinfected, you will get very, very sick from it. And the literature is full of that and full of AIDS-like deaths pre-1960, secondary to inadequately or untreated syphilis. You just have to read it. And the epidemiology is very compelling for syphilis because it's conspicuously absent in all HIV disease when it's later stage. It's a 100% correlation. No AIDS patient ever dies of syphilis, and that's impossible because we know we only treat half the syphilis in any sexually active population. There's dozens of references to that. The British shook their fingers at the Americans in the 70s. I have the references. Look out, you're not picking up the syphilis in your homosexual populations. Warnings, you're only getting a third of it, you're only getting a half of it, and along comes HIV disease and the syphilis disappears. I can't accept that.
While there's already a strong association between syphilis and HIV infection, Dr. Nottenboom notes the extent of decreases in treponemal antibody and seroreversion to negative in HIV antibody-positive persons suggests that the association between HIV infection and syphilis may be underreported. And there's no telling how long this loss of antibody has been going on. As it turns out, only a fraction of Richard Freilich's 500 HIV-positive patients show treponemal antibodies.
About 11% of our total clinic population have such antibodies. That is surprising. I mean, considering the infectiousness or contagious nature of syphilis, one would think that there would have been more people with a history of syphilis, more people with detectable antibody.
Syphilis is going away. I can't believe it's going away because I know from the lifestyle of my friends that when we play like we play, there should be more exanthem of syphilis, more rashes, more gumas, more sores, and more paresis and tabes, yet there is a 100% absence. It's as strong a correlation as the presence of HIV antibody. It never occurs in people with under 200 T cells. It never kills a person. I've never heard of an AIDS patient dying of syphilis. Impossible considering the British warned. I mean, they said you're only picking up half or a third of the syphilis in your homosexual cohorts in the British Journal of Venereal Diseases. They said this is a disaster. You have a reservoir of 500,000 cases. They warned the Americans. Conrad Vischer acknowledges 325,000 untreated cases in 1980. Now, if you look at Sheila Lucart's work, half to two-thirds of that was in homosexuals, in gay males. And then it doesn't do anything? An untreated reservoir of treponemal infection in immune-suppressed people does nothing? Syphilis kills on its own very efficiently, more efficiently than any of the OIs or any of the other infections purported to be operating as STDs within the sexual framework of AIDS occurrence.
Syphilis is an old enemy. It is one of the most profound infections you can have. Syphilis will kill you. There is no doubt about it. What has happened is that we have gotten a very cavalier attitude about this, and the world followed our lead. And it was the biggest mistake any of us made.
And it seems that this mistake is beginning to be acknowledged. This abstract was presented at the 1991 International Society for Sexually Transmitted Disease Research Conference held in Banff, Alberta, by Dr. Sandra Larson of the CDC. In it, Larson writes, "The clinical manifestations of syphilis, which have taken various forms over the centuries, have now been transformed to mimic the appearance of the opportunistic infections and cancers that may accompany HIV infection, as well as the clinical symptoms of AIDS itself."
What we have to do is reopen the inquiry. We are going to have to take a new look at what the cause of the problem is, the cause of men and women now dying. We have to become open investigators. We have to advocate full disclosure from all of our researchers and from our government agencies. We have to be able to know what we're fighting. And maybe we can win. Maybe we can win. Thank you.
For several years now, John Scythes has presented his views at scientific conferences around the world, including here in Amsterdam.
So you can have syphilis and no RPR, I guess that's what I'm trying to say. Does anyone want to comment on that? People never answer my question, they just tell me to go away. I printed 20 questions for doctors, what we don't know about syphilis in the AIDS era. I ran into Ned Hook, Chief of Infectious Diseases at the Johns Hopkins Center Hospital on North Wolf Street. He said, "John, those are the right questions." There's no money and no support from the community, so no one's having a hard enough look at syphilis. The American establishment, the American syphilology establishment, I think is willing to do this work, but the homosexual communities around the United States don't knock on their doors, and they're not going to be, they're generally elderly PhD scientists who are not clinicians now. Syphilis has been relegated to the laboratory and been forgotten as a clinical disease, whereas the people who practiced syphilology in the 50s were MDs and research scientists at the same time, so they did the research plus they had patients. I think that's very important.
One such veteran syphilologist is Professor Anton Luger in Vienna, who wrote to Scythes in 1992 saying, "I agree with you in your hypothesis concerning the role of syphilis as a cofactor in HIV activation and AIDS progression." Another is Hungary's top syphilis specialist, Istvan Horváth, who writes, "Your idea is excellent. I think nowadays only a few people can recognize the reality on the field of AIDS, and only some of them are not afraid to say what they are thinking about it."
These people, as I said earlier, are generally speaking, lab and scientific thinking type people who don't have active clinical practices. Many are elderly, but there are some very young, fresh-blooded people in syphilology. But it's an old profession, an aging profession, generally. Not totally, but generally. And you can't expect a man in his 60s like Jim Miller to take on the HIV steamroller. Why should he? At 65 or 64. And he's a professor of medicine at UCLA. But he's smart, and he just sits back like Conrad and Victoria Vischer and says, well, if no one wants to ask us for our opinion the right way, then what do they expect us to do? I think the community has to go to these people.
Ed Jackson is an AIDS educator who worked for many years at the AIDS Committee of Toronto.
I think attacking science and the very scientific method, the scientific model, it's a hard battle to fight, because you have to have enough credentials and intelligence and understanding of the issues to address it, and people, there are only a few that do that right now, I think.
I would really recommend to increase the sensitivity. I have no right and no affiliation, and therefore I never deal with the bigwigs. I deal with primary care docs who are my friends, and our chief serologist, and one hospital specialist, Douglas McFadden. And I would say that We have published a couple of very interesting things, tried to publish a couple more, and I would say the cooperation has been as much as it could be without the community saying, you know, we want you to work harder on this, we give you our support. As long as there's no support for this argument from the gay community in this city, then no greater amount of money or work will go into it.
Okay, if this is what you're saying, there's reasonable doubt about the HIV theory, so let's therefore set up some sort of methods that would help take us further on this road and demonstrate it one way or the other.
To AIDS activists like Tim McCaskill, these concerns are more than academic.
If, in fact, there is a way of determining the role of syphilis, masked or otherwise, in AIDS that can be answered by a particular study, I mean, I think that there's a very clear argument that that study be carried out, whether you believe that HIV is the cause of AIDS or not. If HIV is closing down people's immune systems so they don't develop syphilis symptoms, and therefore you've got rampant syphilis taking place, killing people under the guise of AIDS or along with AIDS, who knows what, that should be investigated, because it certainly would have direct ramifications on treatment strategies.
AIDS action now!
There's John Scythes' specific question and research project around syphilis that he thinks is not being funded, that will answer some very important questions in terms of the treatment of people with AIDS, then of course AIDS Action Now would be calling for the funding of that project.
We've got lots of research proposals for syphilis in the AIDS era. Very sound, scientific, well thought out ideas. But we need the community to say, now that Montagnier's moved his position, that it's official. Yes, we support the work on cofactors aggressively, meaning that we want to know the answers. Can syphilis selectively kill our friends and be seronegative? That's the question.
For years, the fight for AIDS treatments has been waged by activists like Russell Armstrong, who says there's a lot we still don't know about AIDS.
We need to ask more questions, many, many more questions. We need to pursue answers. It's very clear that we don't have the answers, and although some of the HIV establishment insist that they now have all the answers they need to prove that HIV causes AIDS. Well, give me a break. We don't have all the answers. I definitely think the question of syphilis needs to be researched. If the tests are inadequate, as there's now widespread recognition that they are inadequate, if there are anomalies in HIV-positive people with syphilis serology, I think that this is a very serious question, and I'm appalled, frankly, by the reluctance to pursue this when there's no guarantee that we have the right answer. There's no guarantee that this is going to be right or wrong as opposed to going any other way. We've got some initial information here that looks real bad, and we need to get on it.
I think it's up to the community. If they start to believe that cofactors are necessary, then I hope that they will ask the syphilologists to work on it. I believe that they should if they want to cure AIDS. If they want to actually reverse AIDS, I think you could, in my opinion, with the right immunologic boost against T. pallidum, either by passive immune transfer or selective immunogenesis, meaning you express a component of T. pallidum in E. coli and somehow produce monoclonal antibodies or something.
I asked Ed Jackson why people in the AIDS community haven't got involved in this scientific debate.
Well, I don't think many people understand it. I think it really is a debate that is, if it's understood at all, it's amongst a very few activists and doctors and scientists. However, I don't think that is necessarily reflects the importance of the debate. I think it is important. Just from my point of view as an educator, if Duisberg and others actually show that HIV is not the cause of AIDS, then I think that puts what we've been doing for the last 5 years seriously into question. And so that's pretty serious. And it has led me to think, have we been telling people the wrong thing all these years? So I think it's important. I don't think people understand it, and they'd rather not hear it because it's so confusing. So it says something that people don't want to hear, I think.
I think people love their virus. People don't want to have their science dumped now when it's been so goddamn painful. And if AIDS turns out to be carelessness with STDs in the previous 25 years, then I think a lot of research money will be withdrawn. In other words, if it's not something new and it's not going to threaten heterosexual society because they get their STDs treated early and they are not prior immune suppressed, and if they harbor HIV, it's irrelevant to their health, then we have a major problem in a change of ideology for the homosexual community, which is the most affected community in North America. We will have to be more introspective in our criticism of our lifestyle if indeed AIDS turns out to be the accumulative effect of existing pathogens and death by syphilis.
Michael Callan, who's had AIDS since 1981, admits there's a reluctance to discuss the question of lifestyle.
Those of us who were proposing that lifestyle had a lot to do with how one got AIDS were in the uncomfortable political position of arguing that it was appropriate for researchers to be investigating the gay lifestyle, some of the more excessive sexual practices and drug use and all of that stuff. And that did not create a lot of sympathy in the American population when they began to hear that the median number of lifetime sexual partners for the first 100 gay men with AIDS was 1,150. And when they began to hear that syphilis was a very common marker for someone who was going to eventually get AIDS. So proposing that it was some force majeure, some virus from outer space or Africa that had landed in our community, it had nothing to do with our lifestyle, it was just bad luck, that was incredibly attractive to a lot of gay people.
To me, I don't want to sound like a conservative person, which I guess I am, and I'm not saying that I didn't live the lifestyle. I'm saying that maybe biologically it just isn't possible. The sex-positive lifestyle that gay males lived in the 60s and 70s was a unique experiment in terms of how much sex can you have and can you catch and treat the agents which might make you sick. I think, I don't know whether it's fair to say it was an experiment. People behaved a certain way because we, people, behaved that way because we felt it was safe. We went to our doctors or our clinics at Women's College or at Hassle-Free or wherever, and we were screened, and in the main we didn't seem to have an illness or any illness which could predispose to the disaster that struck between 80 and 85. So you can't be moralistic because nobody did anything that they, I mean, there were people who were outrightly careless with STDs, but I think they were a minority, and many people, they were still often dragged in by contact tracing and treated and given an epidemiologic shot of penicillin if the STD happened to be syphilis. And I think doctors and their patients just didn't think that this could happen. So there is no, it's just bad luck. Maybe you just can't do that with nature. I guess that's how I see it. It's not moral. Can you have a sex-positive lifestyle with unlimited exchange of bodily fluids with unlimited partners? The answer is no. I guess you can't. And if AIDS blows by and slows down, which I think it will, in terms of the acute and quick deaths with which we associated, HIV antibody positivity, and we still do to a certain extent, although it's changing as we've discussed. I think people will always behave differently. They will behave there will not be the same, people can be sex positive, but it's the actual exchange of bodily fluids and perhaps very, very intimate contact that puts people at greatest risk, and I think the experiment failed. The answer is you cannot live that way. Conventional pathogens are enough to destroy you. A combination of syphilis and Joe Sonnabend and Peter Duesberg will do it. You don't need HIV. HIV marks the process. It comes out of its intracellular habitat when you're not well and flags you as a person at great risk for immune suppression, but not necessarily doomed, thank goodness, as the various lengthening, and only lengthening, never getting shorter, cohorts are starting to demonstrate. The worst centers, which have the greatest publicity accorded to them, are San Francisco and New York, and of course there the situation continues to be very sad, and I think that's because they have the worst combination of cofactors most heavily entrenched in their community, especially latent syphilis, which is not responding. The patients are not responding either with treponemal antibody or with anticardiolipin antibody. And we have enough serologic proof now that this should be getting a few $million directed towards it.
I asked Russell Armstrong why there's so little work pursuing different approaches to researching AIDS.
Well, the fairest answer is limited funds and limited resources. We don't have enough researchers in AIDS, in Canada at least. Money seems to flow in narrow channels. Certain researchers get a lot of funds. People who come up with new ideas who don't have those connections don't get money. Or, you don't get money for research if your ideas are not approved by a peer who is associated with the fund granting body. And I've seen a situation where 3 individuals in this city, for instance, 2 doctors and a layperson, came up with a brilliant argument, at least a brilliant question that needed to be answered. And because the peer in that case was very much connected to HIV research and was reluctant to consider this question for reasons that I can't suspect, some of which may have been personal. These 3 would not submit the application because they knew before they started it would not be accepted. That's only, I think, a small, maybe relatively unimportant or insignificant example of what probably happens on a larger scale.
So it's monopoly and politics and money and And if the patients don't revolt, then it'll stay this way. But I will continue still, as long as people are willing to continue to point out what I think are the problems with treponemal infection in the AIDS era. Serology, symptomatically, epidemiology, where is the syphilis, all those questions. It just can't have gone away.